afternoon, and thank you for joining us for the third in a four-part webinar series discussing behavioral health issues for children and families in rural areas. The 2012 Rural Behavioral Health Webinar Series is sponsored by the Child, Adolescent, and Family Branch and the Mental Health Promotion Branch, Center for Mental Health Services at the Substance Abuse and Mental Health Services Administration, in collaboration with the Western Interstate Commission for Higher Education, the National Center for Mental Health Promotion and Youth Violence Prevention, the National Technical Assistance Center for Children's Mental Health at Georgetown University, and the Technical Assistance Partnership for Child and Family Mental Health. The webinar today, Improving Law Enforcement Officers' Response to Children and Youth with Behavioral Health Needs, Strategies that Work, will focus on law enforcement as first responders to emotional and mental health crisis in rural communities. We will offer a presentation and interactive discussion that addresses the underlying factors that can cause negative outcomes when law enforcement responds to youth and mental health or emotional crisis. Additionally, components of an effective law enforcement training model based on the mental health first aid training curriculum will be covered, as well as key elements of a successful training team and the training experience. Now I would like to welcome our two presenters for today's topic. Elaine Clayton is the owner of Clayton Associates, LLC, a team-based multidisciplinary consulting group. She has been deeply engaged in healthcare delivery and advocacy for the length of her career, ranging from bedside nursing, grief counseling, administration, advocacy, and training. She previously served as Senior Program Director at the National Federation of Families for Children's Mental Health. Her work related to law enforcement's response to persons with mental illness and is based on principles of mutual respect, dignity, and safety. Our second presenter, Timothy Denny, currently works at Northwestern Mental Health Center in Crookston, Minnesota as the training director. A graduate of the Rehabilitation Counseling Program at Fresno State, Tim has worked as a vocational rehabilitation counselor, psychometrician, and currently as an evaluation specialist and training director. Other jobs on his resume included directing a nonprofit organization, the rock climbing instructor and wilderness guide, and religious ministry professional. Our learning objectives for today, first one, identify factors that contribute to negative outcomes when law enforcement responds to youth and mental health or emotional crisis. Second, identify steps that family members, caregivers, and youth can take to facilitate positive outcomes when involved with law enforcement to address mental health issues. Identify tips and tools for engaging law enforcement professionals in an ongoing training relationship. And lastly, to identify the key elements of a successful training model, training team, and training experience. Before we start with Elaine's part of the presentation, I'm going to, a couple people have signed on, so I'm going to remute the line again.
The conference has been muted.
And first we're going to do a polling question. The first one, what is your role in your program or community? 911 dispatcher, clinician or service provider, police officer or first responder, family or youth, community-based program provider, court representative, or school resource officer. It looks like we mostly have clinician with community-based program provider, and some representation from 911 dispatcher, police officers and first responders, and family and youth. It looks like we have everyone responded. Okay, so now we're going to go on to our second polling question. Assuming police are responding to a young person in distress and that young person may have a behavioral health issue, which of the following scenarios is the one that you are most concerned with? Is it first, police responding to a call for help in a home setting, or police responding to a call for help in a school setting? Third, police responding to a call for help from a clinical setting, or police encountering a child or youth with behavioral health needs on the street as a witness, victim, or suspect. And looks like we have a majority of people saying it's responding to a call in a home setting, but we have representation across all choices. So it looks like we have a lot of different needs here. Okay, great. So now we're going to go on to Elaine's part of the presentation. Elaine, let me get you on our webcam. There we go.
Okay.
And here we are.
Okay. Well, hi. It's great to be here. And thanks for answering those polling questions. I think it's important for Tim and I both to kind of know who's on the call and what your expectations are about this. I want to reiterate that I am not a law enforcement officer, but the questions that we just polled you about in terms of how, what are the scenarios you're interested in, I have been involved in all of those scenarios for probably about 30 years. And it's from that I'm going to try and bring you some concepts to think about as you work on how to improve relationships between law enforcement and mental health and children and families in your community. One of the first things I want to mention before I get to what's on the slide there is that my own personal experience and my work as an advocate in children's mental health brought me to a place in 2007 where at the National Federation of Families for Children's Mental Health, we developed a partnership with the International Association of Chiefs of Police. They also had an interest in trying to figure out how to improve relationships. I think I should back up just a minute and say the assumption that we're working on here is that there are far too many encounters between people with mental illness and law enforcement officers where there's a negative outcome. And that negative outcome is for all people involved. So back to the National Federation and the International Association of Chiefs of Police, what we did was pull together resources and held a roundtable dialogue that went we brought leaders in from all over the country, youth, family leaders, law enforcement leaders, school resource officers, and all in a room around a round table started having a discussion about what's the problem. One of the most fascinating things, or surprised me, I think one of the most surprising things to me was that immediately everybody kept saying the same thing. You know, you don't understand me. I don't know what you're going to do. I don't know if you are going to pull a gun. So it was very interesting that everybody kind of had the same fears and concerns. So as we started dialoguing about it, we came to ways that some ideas that I think we want to share here. That got followed up by the International Association of Chiefs of Police holding a policy academy, a policy summit, in 2009. The documents that include the recommendations from both of those events are listed on a resource slide at the end of this set of slides. They're available online. I think the one document from the roundtable is a PDF document that will be sent out to everybody after this webinar. Now, I am not going to talk a lot more about those, except that they are incredible resources. I would strongly encourage you to get your hands on them. They have a lot of background information, a lot of recommendations, and a great tool for any community to have in hand. That said, I think what are we talking about? Why do police get called? And we went through that on the poll a moment ago. Sometimes it's a family that's calling for assistance when someone has lost control. And we know that too often community mental health services close down. They're only open 9 to 5. There may not be a community crisis intervention team. And so what happens is that families end up being told to call 911 in the event of an emergency. In many communities, the problem is that nobody told the 911 dispatchers to expect those calls, and nobody trained the law enforcement officers in how to respond to them. So those are the kinds of things we want to get to today. So know that the expectation when somebody makes a call to 911 asking for police assistance may be very, very different than what a responding officer can actually provide. What are the tools that the responding officer brings? You know, one law enforcement officer told me, look, I've only got 3 tools. I've got handcuffs, I've got a gun, and I've got my head. And those are the only 3 tools I have. So you can take it from that the more experience and the more training and the more support law enforcement officers have, the better they can do. what kind of backup do they have, and then what are the options they have, because what are the other mental health services in the community? What are they going to refer to? So those are the kinds of questions that I think we have to consider as we think about how does law enforcement respond. Those of you on the call that are in the mental health field know the statistic that persons with serious mental illness are no more violent than the general population and are actually more likely to be the victim of a violent crime than the perpetrator. And I'm quite accustomed to citing that statistic when I'm talking to law enforcement officers, and one of them finally stopped me one day and said, you know what, I don't care about that. He said, I don't care about that. What I would care about are just the 2% that are violent, because they're the ones I come in contact with. So very important to always understand all the perspectives that are involved in here. By some accounts, behavior resulting from mental illness account for 3 to 7% of all law enforcement calls for service. A training flyer came across my desk the other day from a metropolitan police department that was advertising the training they were providing to officers, and they were claiming that in their metropolitan area that they respond, that mental illness is involved in a response that they make every 6.5 minutes out of their department. So it's a huge issue for law enforcement. We can go to the next slide. I want to talk for a minute about who the police officers are, and I'm so happy to see that we have some on the call today. I commend the communities that were able to support that happening and the 911 dispatchers that are on the call. First and foremost, law enforcement officers are, they're human beings, they're our neighbors, and I'm saying this because I think in most mental health, in most of us that come from the mental health side frequently have a different perspective, and especially those that come from the family side where they may have had pretty unhappy experiences with law enforcement. Most of them very, very committed to their community. Most of them are really motivated by wanting to be helpful. They're taught, remember I said they have 3 things. One officer said to me, I have 3 tools. I have my handcuffs, I have my gun, and I have my head. Well, they're also taught to respond in 3 ways. When they come on the scene of anything, their immediate thing is to assess what's going on. Their second thing is to get it under control, and the third thing is to resolve it as quickly as possible. So know that that's their goal when they arrive on the scene. And all of them are guided by policies, by mandates, whether it's their departmental policy, whether it's a state law they have to follow. They have mandates that may limit their options when they're responding to our kids. And give you just a couple of quick stories. One officer that I knew quite well was making, just on his own time, stopping by to visit an elderly woman with serious mental illness on a daily basis, just to see how she was doing, make sure she seemed to still be on her meds, make sure she was eating. I know a chief in a southern state who takes the time to take the phone calls that come on an almost daily basis from a person in his community who calls asking for help with his stove, that there's a problem with the stove. So there, I can give you 1,000 stories about law enforcement officers taking a really serious personal interest in wanting to make things better. But another point to make about the law enforcement the population of people serving us as law enforcement officers, they have incredibly high rates of depression, of post-traumatic stress disorder, of substance abuse, and of suicide. They have stigma. We talk in mental health about the stigma of mental illness. That stigma is huge for law enforcement officers. If they, many of them are in situations where their policies mean that if they seek help for a behavioral health issue, that they may end up on administrative leave. So, and they are trained to not show vulnerability. So if you just think about, back to the comments I was making about the round table we did, there are huge similarities between the law enforcement population and those of us that are receiving or parenting kids who are receiving mental health services. when I mentioned the policies, there are many states now that require law enforcement officers to handcuff anyone they're going to transport. So that means even if someone is not under arrest, even if someone is compliant, even if someone is calm, if they're going to transport them in the police car, they may be mandated to put them in handcuffs. So that's a really important consideration. If we go to the next slide, let's look at just a few of the issues that rural and tribal law enforcement in particular are dealing with. Safety is first and foremost on everybody's mind in these encounters. Rural law enforcement officers and tribal officers have, I think, an extra consideration here because their backup may be non-existent. It may be an hour away. I thought about if I ever wanted to be a law enforcement officer, I would want to be in a city where the next backup that can, the next police officer is a block away. The next officer may be an hour's drive away. So these guys don't have a lot of backup support. As we talk about, we know that national crime statistics are showing that violent crime is going down, but that's pretty much in metropolitan areas, in urban areas. In rural areas, some of the crimes that are going up include domestic violence and property crimes, and domestic violence crimes are hands down one of the most dangerous for police officers to walk into. Isolation is a big issue for rural and tribal officers. They come from very small departments. They don't have a strong peer group, or a lot of peers, I should say. And isolation, we all know, is tough on anybody's mental health. They have limited access to ongoing training. So the program that Tim is going to talk about in a few minutes is really incredible, and one that's incredibly important. On the next slide, there are jurisdictional challenges for them to deal with. One, just to give an example, is, and one that's been huge on the law enforcement radar screen for a long time, is that tribal law enforcement officers may face things like they can't, on a reservation, they may be limited and not be allowed to arrest or detain someone who is non-native. I find that a mind-blowing situation, but you can imagine the kind of complications that's going to add. The mutual mistrust and this stigma, and I've already mentioned that, it came out loud and clear in the roundtable, and you can read more about that in that document. Small departments, again, that means not a lot of backup for these guys, for these women and men, that if they are having to stop and spend a long time with someone to help de-escalate or to transport, it means time that they're not available for other kinds of calls. And again, the policies and mandates that they may be limited by. And in all of this, we're all facing budget crunches. Law enforcement's facing it. I haven't done it side by side, but it's at least as significant as what we're seeing in the mental health arena. So we're seeing things like school resource officers. Those departments in some places are just simply going away. So let me look at the next slide and just talk quickly about some of the national trends. If you think about this over time, it's been about 40 years since the Community Mental Health Centers Act was passed. And I was working actually in an urban area in a psychiatric unit at that point in time, and that shows my age, right, because that was 40 years ago, but we just absolutely celebrated because we thought that was the answer to everything. We were bringing people with serious mental illness out of the jails and promising them that there would be community-based services. Those community-based services have not kept up with the need, and at the same time, psychiatric beds have been reduced. So we see, in many ways, we're kind of back where we started. At the same time, prison and jail populations are rising, and what we're seeing overall is that the prisons are becoming the de facto psychiatric hospitals in this country. The sheriff in Los Angeles, claims to have more patients than any other hospital or all the hospitals put together in California. This isn't limited to the United States. In the United Kingdom, they claim that 90% of their prisoners have serious mental health issues. So this is a big problem. And one of the things that concerns me with this is the privatization of prisons and jails, because as we talk about how we'd like more community-based services and we'd like to take people out of the prisons and give them community-based services, there's a whole economic engine running there that fights against that. I'll go to the next slide. So I want to talk about a few of the strategies, and I'm talking about these at the 30,000-foot level, not on the ground like Tim is going to talk about in a few minutes. But based on these two academies that we had, the two documents that I referred to, and other resources that I know about, the strategies kind of sound like certs, and it's not a breath mint. Before you go anywhere with this, I think it's critically important for any community to make sure that communication is really solid and open and transparent between families and youth, between mental health, between community-based services, and between the law enforcement departments. Collaboration is absolutely critical. As I've talked about some of the challenges that police are dealing with, I hope that helps you think about it's not a matter of just telling police or training police to do a better job. There's got to be community support there behind them to support their budgets, to support, to help them have more flexible policies to work with, and to have services that they can help get people to. The relationships are critical. They've got to be built on mutual trust and respect. And I think this can be incredibly challenging when there is a negative experience in a community. I worked in one urban community where the families in the community, the community members were absolutely up in arms. There had been a police shooting and a young man had died as a result. And, you know, as I talked with the family members, they kept saying to me over and over, they knew, police knew, they knew he was unarmed. They could see he wasn't doing anything. They shot him and killed him anyway. And they kept saying that over and over and over again. And we spent some time talking and trying to deconstruct what they knew and what they didn't know, to get down to getting people to understand that they didn't have all the information until they brought the other perspectives to the room. They really believed in what they had witnessed, and the witness testimony can really drive negative relationships in communities. You know, I saw a statistic the other day that the majority of wrongful convictions in this country are based on witness accounts. So it was eyewitness accounts that convicted those people, and people are adamant about what they saw. I don't know how many of you on the phone, on the webinar, were around in the Washington, D.C. area in 2002. If you weren't, you probably heard about it on the news. But in the fall, this time of year, 2002, we were experiencing here in Washington, D.C., we were under siege by what's been come to known as the D.C. snipers. People were dropping from bullet wounds randomly. There was no known pattern. It was happening. It was a mom pushing a stroller down a sidewalk. It was somebody pumping gas at a gas station. It was a woman loading the car at Home Depot, putting her packages in the back of the trunk. And it was a horrible community situation. I bring this up because I want to talk about that eyewitness piece again. The witnesses to these shootings initially said it's a white man in a white van, and the police took that and went with it, and that became what everyone was looking for, a white man in a white van. When they were finally caught, the D.C. snipers were two African-American males, and they were driving a blue Chevy Capri. And they had actually, before the last shooting, had been stopped and told to move on, and that, the police had them right there and didn't recognize them because of eyewitness accounts. So I share that story just because I want to say that so many times communities get up in arms about what police are doing based on eyewitness accounts. And I just wanted to bring that up, that eyewitness accounts are not as reliable as we think they are. So we need to, again, take a step back, work on communication, work on collaborating, work on building relationships so that you can hear each other out. Some of the strategies that, and again, Tim is going to talk in detail about a training that he does, but some of the kinds of strategies that we're seeing communities use that are fascinating. I happen to live in Alexandria, Virginia, and every year there is a barbecue for first responders, and it is done during the shift or at the time of shift change. It's done at a place that's near the police department, so it's easily accessible. They can stop and get free food and drink on the way to work or on the way home from work. And what that's done is to build personal relationships between a population of people that were pretty disenfranchised with law enforcement and law enforcement getting to know them. So that's the kind of relationship building events that can happen. In the UK, they're doing things like informal chat times where law enforcement officers can sit down with staff from the mental health facilities and talk about the experiences that they're having and getting some non-judgmental support in how they might do their job better. There are also communities using things like databases and information cards as ways of notifying law enforcement about what the mental health issues are that a person might be having, what kinds of things might escalate their behavior, what kinds of things might help to de-escalate, and what kinds of resources exist for them. Again, if you go to those documents, you'll find a lot more information about those kinds of strategies. I want to tell you also that on I think the last slide is our Tim's contact information and my contact information. On there, you'll see my Twitter. Is that called a Twitter address or a Twitter? It's like a Twitter handle. A Twitter handle. It sounds like a CB radio again. But okay, so my Twitter handle is on that contact thing. Next week, I'm going to be attending the International Association of Chiefs of Police annual conference. And I am there specifically to be looking for other resources, other ideas about how to help communities create environments where crisis intervention has more positive outcomes. So if you want to follow me on Twitter, I will be tweeting, right? I will be tweeting from the IACP conference. I think that's it on that slide. This is the slide that I want to encourage communities to spend some time with, because while Tim's going to talk about training law enforcement officers, and that's where a lot of the attention goes, I want to say that providing training to youth and their families is critically important as well. I'll give you a couple of stories to make my point. On more than one occasion, I've known situations where a family feels that they need to call for support because a child or a young person is out of control, maybe threatening to harm themselves or other people in the family. And so mom or dad or a caretaker calls 911 and asks for help. When the law enforcement officers arrive on the scene, the adult that made that call, rushes out to the curb, screaming, trying to yell what needs to happen to the police officers. Now remember, the police officer's first job is to assess, get control, and resolve. So the police officer gets out of his car, her car, the first thing they see is someone running at them, screaming. They haven't yet had an opportunity to assess the situation. So very important to know, I think, for family members that may be in a situation and youth that may be in a situation where law enforcement officers are going to call to know what to expect, what's going to happen when police officers arrive on the scene. The first thing to know is that when the police officer arrives on the scene, they are in charge. So you make no sudden moves, you keep your hands visible, you answer their questions, you let them do their job, and their first task is to assess the situation. That I think is important in any given situation. I myself one time had one of those a security alarm on the house, and it was set off, and the police came. And it was winter, so I had a big, heavy coat on. I came out of the house. I walked towards the police car with my hands in my pockets, right, because I'm bundled up. It's freezing. And I'm trying to tell them it's really okay. There's no problem. I'm so sorry. I watched they backed the car up. They got behind their police cars. They had their hands on their guns. And I suddenly realized, oh, my God, look what I'm doing to them. They're responding to a burglar alarm. And here comes this woman out of the car, bundled up with her hands not visible, rushing towards the police car. So help them do their job. And we can all do that by knowing ourselves how to respond, and especially our young people. Everybody needs to know the officer's in charge. You don't make any sudden moves. It's really important for youth to know that if their parent is not present, they have the right to ask for their parent to be called. They also have the right to make a decision about whether or not they want to disclose that they have a mental health problem. And not everybody does. So if that may be a conversation you want to have with your young person ahead of time. If they're not comfortable disclosing that, then they need to think about how are they going to explain their behavior, how are they going to explain their need for support. I'm not, I don't want to read this slide, but I do want to tell one more story before we take that slide down. And that is, I want to acknowledge, and I know we have some 911 dispatchers on the call, an often overlooked population of people, an often overlooked role in these situations. I've mentioned isolation. 911 dispatchers typically work in pretty isolated situations, and they are sitting at the phones taking emergency calls. Now think about what that feels like emotionally, just to be taking one crisis call after another on the phone and trying to send people out to help. I was involved in a situation a few years ago where there was a young man who was out of control and seriously dangerous to himself, not in touch with reality. It was a very, very fragile situation. And I totally give credit to the 911 dispatcher we worked with that night for basically saving that young man's life and making sure that we had a safe resolution of that. That 911 dispatcher kept the lines open. She had several lines open. I was involved because I was a friend of the mother's. The mother was on the line, and the responding officer was on the line. Now, she could not put me to where I was talking to the responding officer, but she kept the lines open and communicated back and forth in a really calm way. So we were able to hear from the responding officer what he was seeing, what he was saying. We were able to get information to the responding officer from the mom about what were things he could say to help calm this young person, to help this person feel safe. And that kind of back and forth communication was absolutely critical. So I go back to the things that I'm talking at the 30,000-foot level. I think the critical things are the collaboration and communication, building relationships, providing tools for law enforcement officers, and working together to make sure you've got the community services so that law enforcement isn't the only, so that they're not the only thing. They've got to have some way to provide follow-up help for young people. On one of the last slides on this presentation, you'll find, I'm not sure which number it is, but there's a list of additional resources. Tim's going to talk about an incredible training that he does that's on-the-ground kind of experience. but there is a slide back there. There are multiple curricula out there. We listed some of them on that slide that's called additional resources. There's an emotional CPR, there's mental health first aid, there's crisis intervention training, many, many things. There's also in the works right now, the IECP is working together with the Memphis Police Department and NAMI to develop crisis intervention training specific to youth. So there's lots of resources out there. We can help you find them if they're not in the slides or in the resources we send out afterwards. And again, I'll be tweeting what I learn while I'm at the police conference.
So now we want to open up the lines for questions, and we don't have any submitted through the Q&A box. So if you would like to ask a question for Elaine, you can press 7 on your phone to unmute your line. If you can't think of a question now, we'll have another question session at the end of the presentation as well. So press *7 on your phone to unmute your line to ask a question. Okay, it sounds like we don't have any questions just yet. So I'm actually going to remute the lines again.
The conference has been muted.
And now we are ready for Tim's part of the presentation. So Tim, I'm going to get the webcam on you, and you can press *7 to unmute your line.
There we go.
Perfect.
All right. Well, our purpose for this part of the training is to just talk about increasing the ability of law enforcement and correctional professionals to avoid escalating a mental health crisis and to also de-escalate crises when they arise in their work. And one of the things that we emphasize, and I'll make that point here, is that as law enforcement and correctional professionals come into a situation where there is a crisis, they will either escalate or de-escalate by their actions. We make that really clear in our training, and that they should be thinking about that and choosing wisely the path to de-escalation. It will save a lot of time, trouble, energy, and paperwork at the end of the day. Our intended audience for our training, police officers, deputies, certainly correctional and probation staff. And the setting in which we're making this operational would be the 6 rural and frontier counties in northwestern Minnesota. We have 6 counties up here, about 6,500 square miles, and about 65,000 people. So that's a little bit of our situation. We have a polling question that is up there, so if you want to click in your answer, the most likely team of first responders to a serious mental health crisis in your service area are, and you get to pick your choice there. So go ahead and do that.
And our choices are law enforcement only, mental health professional only, mental health professional and social worker, school administrator and mental health professional, school administrator and law enforcement and emergency medical staff, and lastly, emergency medical staff and mental health professional. It looks like we have the majority of the group saying law enforcement only, but also representation from law enforcement and emergency medical staff, mental health professional and social worker, and school administrators and mental health professionals, and emergency medical staff, mental health professionals. And it looks like we have everyone answered. Back to you, Tim.
That's a pretty typical response in a rural setting, particularly, that it's law enforcement and emergency medical staff who wind up responding to mental health crises. So that points out on the next slide our training need that in our area, we're a system of care, SAMHSA-funded system of care community whose grant funding actually runs out day after tomorrow, so we're just about done. But as that process moved forward and we became a little more consumer-driven and coordinated, a little more culturally responsive and community-based, we realized that there were some weaknesses in our system. One was that we had not done any work with law enforcement. Another area where we've done some work is with schools and then again with clergy. Who do people report to first when they're in some kind of crisis. If it's at school, they're reporting to school personnel in their communities. They often call their pastors. If it's a serious problem, then often law enforcement. So we started working from that starting point. Our goal was to train these frontline providers to impact how they respond to citizens in a crisis. You can go to the next slide. In our area here, the obstacles were small agencies. Our average agency size is about 8 officers, but we have some that have only 2 sworn officers. Our jail and probation staff sizes are similar. This makes time off for training very difficult. That was covered a little bit in Elaine's presentation, but when you just don't have the staff to cover time off, particularly if there's other things going on like vacations or up here it's hunting season and the harvest. Certainly job layering is also difficult. Many law enforcement officers, I think maybe the majority, have side jobs, things that they do to help augment their income. Here we also have difficulty with travel distances, just pulling people together for training. And then the sheepdog versus sheeple mentality. This is present to varying degrees in each individual law enforcement professional. They are trained to be sheepdogs, to watch out for people. The people they watch out for sometimes in their minds are what they call sheeple. Because of that, there's sort of creates sort of a professional separation between the community and law enforcement responders. But it also, much like doctors want to be trained by doctors, lawyers want to be trained by lawyers, law enforcement professionals want to be trained by law enforcement professionals. So we had to take that into account as we designed our training. Next slide. The first thing we went to was the crisis intervention team training. That didn't work out very well for us because of the 40 hours that are necessary. These smaller agencies just can't part with a staff person for that long and meet their other requirements. So we took mental health first aid. I worked with the Minnesota CIT Officers Association, and we developed a 2-day course. It's a 20-hour course with mental health first aid as the core curriculum. We use one of their trainers jointly trains with me. He is a sergeant with the Minneapolis PD. So we deliver the mental health first aid course in its entirety. We don't cut any corners on that, but we add some additional topics to it. We talk about excited delirium, which is a drug-induced medical issue that often leads to the death of a person while they're in custody. We talk about veteran issues. We talk about officer mental health. We talk a lot about adolescent issues and the kinds of things that set apart responding to adolescents in crisis. And then we spend a good amount of time in de-escalation scenarios. We bring in CIT-trained actors and law enforcement coaches, and the attendees actually spend several hours on the second day with these actors and coaches working through ways to respond so as to de-escalate a crisis. That's the part that is the most frightening to the officers on the way in because it's a performance thing. But then at the end, they tell us that that was the most transformational part of the training. The total training time for this course is 20 hours. We do 2 10-hour days, so they're very long days. We put lots of breaks and things in there because we firmly believe that the mind can absorb what the seat can endure. So we work hard to put in breaks and to have some other things to increase comfort. Next slide. Along that line, some of what we've learned, we've already talked about sworn officers involved as trainers. A 2-day maximum limit allows small agencies to part with their staff. Comfortable surroundings and privacy for our discussions, certainly food. It doesn't have to be donuts, but donuts help. We put in lots of discussion time, and we use a lot of examples from policing and correctional situations. And those things make the training seem to come alive for our team. Next slide. We talked a little bit about the actors and coaches with CIT experience. That's been highly successful for us. Every state has a certification body for law enforcement. In Minnesota, it's called the Minnesota Post Peace Officer Standards and Training. There's a comparable group. We submitted our curriculum to them, and they approved it, so the trainees get 18 post continuing education credits. That's very, very helpful in a rural setting because they have a very difficult time getting away for training from here. So we're able to meet a major chunk of their training need in a 2-day event right here in the community. Saves a lot of time. Letting cops be cops, I think, has been really good. There's a lot of humor involved. Sometimes the humor might not seem appropriate, but we let it happen in the room. It allows officers to blow off steam around some very difficult topics. We let them talk about their fears. We discuss conflicts between good mental health approaches and good police work because there are some conflicts in terms of how they've been trained. So that's been an important part of it. We can be honest in the room, and I think that helps them to deal with the difficulties of assimilating good mental health responses into good police work. Next slide. We've also done some good marketing with the chiefs and even with the officers. Certainly we put flyers and letters out there, but I go around and visit agencies. We host chiefs' lunches. That always seems to bring them out. We've created some tools for use on the street. We'll talk about a tool coming up here in just a minute. But these tools have made their jobs easier. And then we go to the departments and we sort of ask the question, what can we do to help you meet the needs of your officers as they work with people on the streets? And we've gotten some really good responses back. We've been able to tailor some additional help for specific agencies to meet their specific needs, and that's really helped to build some good bridges. Our county social services directors have been good about funding this training up till now, and they've liked it so much that they're now asking for the same training for some of their staff. We actually have a 2-day training starting tomorrow that will be a mix of social services, emergency room staff, our mental health crisis responders, and law enforcement. Bringing them all to the same training table has been very useful, and it's increased communication between the agencies. Next slide, please. So here's a little bit about what we've learned. Certainly those law enforcement trainers or ones who have had crisis response backgrounds are vital. Choosing the right location is very important. The scenarios that we use are graphic. Our first training that we did was in a church. We learned a really good lesson there, so we won't be doing that again. Other public venues don't work well. We've been offered to use local colleges and that kind of thing, but you know, having a mental health crisis actor doing a really good job with that can create some serious issues when people walk by in the hallway, so not a good idea. We tend to use, like tomorrow we're using a National Guard armory. We've used training sections of a sheriff's office. We've even used fire halls, so anything like that can be a good location. Food is important. The post-accreditation is important. Being open to tough conversations and allowing those things to happen. It's okay. Letting people complain, vent, share what didn't work, those are all really good things. Being aware of conflicts between service sectors. We had a very difficult exchange at one point between corrections and law enforcement. We got that out in the open, and it actually led to some good policy changes. So letting that kind of thing happen is okay, but it needs to be managed. And then cooperation between responders and providers has improved the more we do this. So that's been a really good lesson for us. Next slide. We worked on a law enforcement guide. We wanted to make it a pocket guide. I'm going to hold it up here. Obviously, you have to have Captain Kangaroo-sized pockets for ours. But that's because we couldn't get a local print shop who could print one any smaller. But the pocket guide has been very, very useful for law enforcement in terms of giving them clinical recommendations, mental health facts and implications, identifying disorders, a whole section on psychiatric medication, glossary of all of the acronyms that we use, and then certainly the last section in it is what we call the Ghostbusters section. Who are you going to call? And that's all in the back, so for the whole region, they know who to call in each county. If that number doesn't work, then who's the next thing to call? So that's been a really good tool for us. If you can design your own if you want, because it needs local information. We got our base unit from Massachusetts, and if you send me an email after this, I can give you the exact location where to go for that. But they sent us their original, and then we were able to rewrite that into a usable product for our region. Next slide. So what have we seen so far? Since 2009, we've trained 60 officers, deputies, jail staff, and probation agents. We're going to be training probably 35 more over the next 2.5 months. It's the required training now for new hires in several of the agencies. We've had 2 instances that we know of where officers decided to try to de-escalate instead of shoot, and they were successful. We've had successful officer-led suicide and crisis interventions where our mental health team got there actually too late to de-escalate because the law enforcement had done the job. Officers report that this is the most useful training that they've received since they became professionals. And we've received a lot of support from the chiefs. They really like the success. They like the lower costs. They like the better resolutions and outcomes. And they really like the high contact hours for certification for their employees. Next slide. So what are we doing from here? We're just looking at expanding. Certainly EMS, fire, guardians ad litem, child welfare. We're starting to market outside our region. I think we've got a product that's useful in greater Minnesota, so we want to move forward with that. We're constantly improving our curriculum and our scenario training. And we're also reaching out to tribal law enforcement. We've not done well at bringing them in to the training, but we're going to be trying to be much more intentional about that in the future. Go ahead, next slide.
We're actually at our question slide already.
Yep.
So I actually have one question that was submitted. I'll read that right now. And it is, do you have specific guidelines for how you handle children and adolescents with autism spectrum disorder or Asperger's syndrome?
You know, we don't have specific guidelines that we train to. We explain sort of the how different mental health disabilities manifest and what that might mean in terms of crisis de-escalation, in terms of things like proximity to the person, hand movements, you know, threatening movements, things that might be perceived as threatening. It's all under that theme of escalating or de-escalating. And we help them understand how people with various disorders, anxiety disorders, autism spectrum disorders, all of these different potential underlying causes for a crisis might respond differently than the average person on the street. So that's sort of been our approach. Each agency has their own protocol, and so it's difficult to give a set, this is how you handle this. But we do give them the background information that they need to think, you know, to use that third tool that they have, their mind, when they're out there and making a difference on the street.
Okay, I wanted to also add that there are a number of autism-specific trainings available. I'm going to go to a workshop on one at the ICB conference next week, so again, I'll tweet information about that. Montgomery County, Maryland, where Rockville, where SAMHSA's headquarters are, their police department has an incredible training there on autism and responding to folks with autism. And they have a little button. If you're familiar with the autism advocacy. I don't know which organization has it, but it's this little thing that looks like different puzzle pieces put together. Yeah, and they made a pen for that, so that police officers that are trained in how to respond to folks with autism have that pen. And that was one of the things we found that's really attractive to police departments, is to have a pen to wear with it. But yeah, so there are autism-specific resources, and we can send some of those out later, and I'll have more information on those next week.
Good call.
That is a great question. Thank you for asking that, and thank you for your answers. So we want to open it up. If you have a question, please press *7 on your phone to unmute your line, or a comment.
Hello.
Hello, welcome.
Hi, this is Bob Kurtz from North Carolina. I help coordinate CIT programs around our state, and one innovation you mentioned, or one thing you mentioned about the rural officers having difficulty going to CIT trainings was a issue here in our state, and one of our CIT programs decided to take a segmented approach where they would offer their CIT training a couple of days, and then and then after a month or so, they would offer another 2 days. So eventually it would be the 40-hour training, but spread out over a period of time. And we evaluated that to compare it to the results of the training delivered in that 40-hour week, and found very little difference, providing some support for that variation on CIT training. So that might be something to consider as well.
Thank you very much. We actually toyed with that here, and we offered it at one point, but we were having difficulty getting commitments to the second half of the training. And that was, we were looking at that same model, and for whatever reason, we were having trouble getting people to commit to coming to both. They would say, I can go to the first one, but we're not sure about the second one. Well, that sort of made us a little leery of proceeding, so we sort of pulled that back off the table. But we like that idea, and I'd like to maybe hear more from you if you could send me an email about some of the things that you did to make that work for you.
Sure, I can send the results of the study that we did.
That would be great.
Be happy to.
Thank you very much.
I think that points to the importance of figuring out what's going to work for your community and working with all the players involved.
Yeah.
But it's really good to hear that the training results, that you got the same outcomes with that segmented training. So yeah. I would also, Bob, be very interested in what your results are.
Sure.
This is Jim from Rome, Georgia. Am I on?
Yes, hi, Jim.
How are you?
Good, how are you doing? What's your question or comment?
Well, I am Georgia is a state that has embraced 159 counties from the north to the south have embraced the CIT program based on the 40-hour Memphis model. It is, it's uniform and it meets the specific criteria. Now, granted, larger municipalities find it much easier to attend, and therefore a greater percentage of them are trained rather than the smaller rural areas, and obviously that's the reason why we're talking about this today. However, the comment I wanted to make is, having been somebody that's taken Mental Health America, the 2-day class, and try to compare it with a 12-week class, there's no comparison. I'm just saying from a NAMI's perspective, there is a 12-week class that goes over mental health. The mental health first aid curriculum, from my perspective, is exactly what it is. It's a first aid. It doesn't go into any depth into the type of mental health issues and other issues as well, as does the first 2 days or first 3 days of CIT. And I think as long as the country and the international CIT program has seemingly adopted that, when you start cutting corners with your program, and we don't want to do that. And I just gathered that, given a choice between a 2-day course and a 4-day, 5-day class, everybody's a 2-day class naturally. And let's not paint that picture, though, as more appropriate across the board. That's my point.
Sure. Well, thank you. The CIT really is the gold standard, and that's what we would like to see everybody take, the full 40-hour course. And we're still scratching our heads as to exactly how we're going to move that forward here, just given the difficulties of getting officer time off.
Oh, I totally agree, and we grapple with that as well, and it is very difficult. I don't know the answer to it.
If you do figure out the answer, though, you be sure to call me. The CIT really is the gold standard, and we want to make that really clear that we have adapted a model that works well. But your point is well taken, that if we get a full 40-hour training, that rocks.
Right, and we cannot get there are so many components that avoid the program because of it being 5 days long.
Yep.
You mentioned it, the EMS, the 911, they just can't afford it in any community. So I think it doesn't, like you said, needs to be tweaked somehow to meet local needs.
Okay, do we have any other questions or comments?
Hi, my name is Lynn.
Hi, Lynn.
I'm calling from Vermont. And I apologize, I had some technical difficulties, so I might have missed this in the beginning, but can you tell me generally the cost to implement the mental health first aid training?
Our cost for doing the training for 25 officers is going to be roughly $4,500. So it's not too bad of a cost per person. That covers food, venue, trainer time, mental health first aid books, hotel rooms for our trainers and actors and coaches, and it pretty much covers the waterfront.
Okay, great. Thank you.
Mm-hmm.
Okay, do we have any more questions? Tim, we actually, we are ahead of schedule, so I was just saying to Elaine that from the questions that were submitted through registration, if you had any that you wanted to answer, this would be a good time to do it.
I have a question for Tim, actually.
Oh, great. All right, Tim, you're on the spot.
This is Elaine, and Tim, I'm wondering if you would talk a little more about the mental health actors. What's their preparation? What's their background? Do you work with the same ones all the time? Do you have different ones?
There's a company out of Colorado, I think they're in Denver, called the Crisis Company, and they are a vendor that supplies actors for CIT training. So I'm not sure, I don't set those up, so it occurred to me as we were going into this webinar that I don't have their contact information, but I'm sure you can Google them. So the actors that we get are part of their stable of actors that they have around the country, and they, some of them are like professional or semi-professional actors from the Minneapolis area. Some of them are actually mental health staff at inpatient hospitals, and they do this as a side job. They're trained, and they do an excellent job. They're very believable. They're very competent. They work very well with the officers. As the officers do well at what they're supposed to do, the actors respond appropriately. If the officers are doing poorly, the actors make them pay for that. So it's actually real-world kind of training.
Oh, very cool. Thank you.
Okay, somebody asked a question ahead of time about working with veterans, mental health programs, information that could impact families. And I just wanted to point out a couple of resources that might be useful. If you go to the SAMHSA, Substance Abuse Mental Health Services Administration website, they have a series of webinars on veterans and veterans family services. And then there's also a group called the Military Child Education Coalition, and that is a good group to access as well. You can get all of that off of the web.
There's one more resource I would add to that list, Tim, and that is, let me see if I can get the website right. It's BRATS, B-R-A-T-S, film.org. It's produced by Brats Without Borders, and it's an independent nonprofit that is run by adults who grew up in the military kids. Addresses a lot of the mental health issues.
I love the name.
Yeah.
Before we go into any other questions, I just want to bring light to the participant feedback that I have up. You can actually fill it out here. We will not see your answers. And, well, at least not right here. We'll see them later. And I will also be sending out a follow-up with this link as well that you can give us your feedback. And we'd love to hear from you and know what went well and what we could do better and what else you'd like to hear on. So, Elaine and Tim, are there any other questions from that list you'd like to address now? Now is the time.
I don't think so. I think there were fabulous questions sent in. I think I speak for Tim and I both when I say he and I both would be very interested in hearing from folks if you're looking for more resources that we might be able to help find for you. In terms of the question specific, I think the autism one was important, and we can find resources on that.
Okay, great.
I think the answer to one of the questions, what options do local law enforcement officers have in small rural areas to assist youth in emotional crisis? That's going to vary place by place, but I think if you're in a position to help facilitate conversation and coordination, good place to start certainly is law enforcement training, but then talking with whoever your crisis response team would be, your emergency department at your hospitals or clinics, talking to schools, and even talking to churches. These are all places where people present in an emergency. And just getting all of those sectors on the same page and maybe talking to each other could greatly increase the probability of finding crises earlier and having a more comprehensive approach to resolving them. So I would just encourage people to think about that. We've stumbled into that. Certainly adding schools and clergy has been, we've had to work hard at that, but it's been very fruitful for us.
Okay, good. Thanks, Tim. So we don't have any other questions. Then I think we're ready to wrap this up. I just want to say to everyone that if you've registered, the slides will be sent out along with the contact info and the resources in a follow-up email tomorrow. And this webinar will be posted and archived on our website, which will also be addressed in the email. So that way you can look at it again. You can also send it out to other people as a resource. And also, please just give us your feedback. We love to hear from you. So, Tim and Elaine, if you have no other comments, I think we're ready to wrap this up.
Very good.
Thank you, Tim and Elaine. You did a wonderful job. And thank you, everyone, for participating.